Hello and welcome to this Rural Doctors Webcast. I'm Simon Stokes. Thanks for joining us. In this webcast, we're going to look at some multicultural health issues and we'll visit two organisations. Later on in the program, we'll speak to staff from the Multicultural Women's Health Centre, ISHA, about the challenges new entrants can face in accessing healthcare in an unfamiliar country with an unfamiliar health system. But first up, we visit ASSETS, the Association for Services to Torture and Trauma Survivors, where Dr. Olga Ward met with Clinical Services Manager, Marnie Williams, Consulting Psychiatrist, Dr. Sue Lutton, and the Medical Director of the Humanitarian Entrant Health Service, Dr. Eason Thambiran. They spoke about the services ASSETS offers and gave their advice about how to identify and support clients who have experienced torture or trauma.
Sue, Marnie and Eason, thank you very much for joining us today and welcome to the program.
Thank you. Great.
You're from ASSETS. It's not an organisation that's looming high in the general practice radar. Could you tell us a little bit about what you do here and particularly what are your roles here?
ASSETS is the Association for Services to Torture and Trauma Survivors. So we're a non-for-profit organisation in Perth, working with people from a refugee background and also working with asylum seekers. We run a whole range of different programs, from working with people individually all the way through to community capacity building, and we offer an extensive range of training. And we have about 50 staff working in our office at the moment.
What's your role, Marnie?
I'm the Clinical Services Manager, so I'm on the side that is mostly working with people individually. We've got psychologists, social workers, counsellors working one-to-one with people, and we also run some support programs around that to complement the individual therapy, like body therapy, and we run a number of groups as well.
And Sue, what's your role here?
I'm the psychiatrist that works with ASSETS, so I work with all the staff and will help with assessments, looking at psychiatric issues, a lot of trauma. So I help with making assessments, management and supervision and support for staff.
And Eason?
I'm actually a ring-in. I don't work for ASSETS, but I've worked with ASSETS very closely over a number of years. My background is general practice, and I currently work with the Humanitarian Entrant Health Service, which is a statewide refugee health service, part of the Department of Health of WA.
Given that a lot of our audience is country doctors, how do they access this kind of service when, say, a detention centre is built in their town or a refugee family moves into the town and they don't really know where to start?
You've got two detention centres in Western Australia at the moment. The first of them is the big one out at Yongan Hills in Northam, and ASSETS actually has counsellors working in that detention centre. So the people responsible for the medical management of those clients is IHMS, International Health and Medical Service. And if a GP was to have contact with someone in that centre, they could let IHMS know that they thought the person needed trauma counselling, and IHMS would refer them into ASSETS. The other detention centre in Perth at the moment is PIDC, which is out at the International Airport. And really similarly, you could just let the detention centre know that you thought the person needed trauma counselling.
Okay, so Marnie, it sounds like there are a lot of services offered through ASSETS. Can you tell us about a few of them?
So when people are initially referred into ASSETS, they come through an intake service which initially assesses them, which is quite an important service because from there we can also know whether or not they're an appropriate client for ASSETS, but more than that, whether they also need assistance in some broader mainstream links. So the intake will ensure that they're linked to all the different services that they need to be. Then when people access one-to-one counselling, as I mentioned, there's a number of community and complementary services around that. So you could perhaps access body therapy if it seems that programs such as relaxation or mindfulness or massage are also going to assist your recovery. There's family and relationship counselling. There's a youth program, so for young people who may also be struggling with the impact of torture and trauma. A vast array of community programs, including a community development officer who goes out to individual communities to see what assistance they might need in improving the capacity of their services. We also have a volunteer program, so we can link clients with Australians in order to perhaps get some support in social arrangements or learning English. We run a lot of programs in schools, so we've got a Children in Cultural Transition program, which runs an after-school program assisting children with settlement issues, and we also have a Families in Cultural Transition program, which works with adults, once again assessing them with settlement services.
Where I first heard about assets was that some of my colleagues had done the course that you run for general practitioners and other interested health professionals. Can you maybe tell us a little bit about what sorts of things you would go through in a program like that, and how that, maybe Ethan can tell me how that links in for you with your general practice work?
Well, Assets runs a number of training courses aimed at different audiences. In the past, we've collaborated with the Royal College of GPs to put on workshops for GPs here at Assets. And the program is divided into two parts. It starts with an introduction from Marnie and myself, just looking at some cultural issues, some general health issues, using interpreters, understanding the conditions that are prevalent in some of the migrant and refugee populations. And then after a break, Sue takes over and focuses more on the psychiatric aspects of the refugee health, looking at the consultation and dealing with those issues in more detail. Mm-hmm. But there are many other courses that Assets runs.
Yeah, we do. We run about 4 core units every year, starting with the orientation to the refugee journey, which is a great course that just takes people through what they can expect a person from a refugee background would have experienced and the possible types of impact that can have on someone. We also run a cultural competency course, which is really about just increasing your ability to work with people from culturally and linguistically diverse backgrounds. We do counselling approaches to working with cold clients, and we also do a working with interpreters program. And working with interpreters is one of the areas that we do a lot of advocacy with other organisations, particularly in the mainstream, around ensuring that they use interpreters with refugee clients.
Yeah, now that's something that comes up a lot for general practitioners. Sometimes we'll have to use a family member as an interpreter, which I never find absolutely ideal because they tend to filter things a bit. Maybe Sue or Ethan, you could talk us through some of the principles of using an interpreter service and some of the things that come up for you?
I would always use an interpreter every time if possible. Sometimes you think there's enough English, but it's really not for the level that you would like to work at, and I agree, family members is fraught with difficulties, especially about confidentiality and what people can say in families. So I think it's really important to use an interpreter as much as you can. And it's easy. It's easier than you think. One of the joys when you have an on-site interpreter that I have found is it frequently slows the interview down. You've got time to think. You read a lot of non-verbal cues with the person, so you're often tuning in at another level as well. So it can be very helpful. Yeah.
Yeah. Ethan, what's been your experience?
We do need to get the message out that using family and friends is not the ideal situation. I think it's okay to use family and friends if you're getting simple demographic information, telling someone about their next appointment, things like that. Or if you're doing something that's, I guess, recurrent routine care, say someone's coming in for a wound dressing, it's pretty straightforward, there's no deviation from the normal standard of care. The problem with using family and friends is there's 2 main problems. One is around accuracy. You can't be sure that what the person is interpreting is correct, whether they're using the correct word for liver or backache. You cannot be sure that that information is actually being transferred. And what I say to my students is, if you can't ask your patient, are you allergic to penicillin, and they understand and give you the correct answer, then you're not actually providing quality care. The second thing is around confidentiality. When we use professional interpreters, we know that the conversation is going to be confidential. They're not going to discuss that with other members of the community and mention that, hey, did you know that Mrs. Jones has hepatitis B? So confidentiality is really important. And I think the last thing to mention, of course, is informed consent. Whenever you're doing anything that requires informed consent, you must use a qualified interpreter and document that interpreter's name or the job number.
As a country doctor, I think sometimes we'll be faced with maybe just one patient or just one family who's been through a trauma situation, who's a refugee from somewhere, who for some reason has settled in our community or is doing some work in our community. Who do I ring for some assistance?
Assets does have an intake and advocacy service. So unfortunately, because there's such a sparse population in many of the rural and regional areas, we don't actually have counsellors working out there. But we're certainly always available to talk through any issues with GPs. And one of the services we do offer is external professional support. So, you know, whether it's informally by just ringing to talk through some issues, or whether it's actually having somebody who's formally talking to you, say, you know, once a month or once every 2 weeks about any issues that are arising with refugee clients. At the very least, we're always able to offer a consultation service. Clients can refer themselves. It doesn't have to come through a GP, and of course our services are free of charge. So there's quite a lot of ways that clients can access the services themselves too. I think it's important that GPs realise there's so much that they can do themselves. It is often sort of another area of anxiety where people feel they need to get them into a specialist torture and trauma service. But, you know, in actuality, creating that sense of safety with the patient, allowing them a space to talk about some of the things that they're experiencing, as Sue's mentioned, just normalising what's happening to them, can actually just make vast improvements for that person as well. So, you know, I don't want GPs to feel that the moment they get a refugee client, the moment they think they might be trauma, they need to get them into assets, you know, particularly if they just ring us and want to talk about some of the things they can do themselves. They're going to be supported in their area.
Yeah. And do you also support local regional mental health services?
Through the external professional support we do, and through the training programs that we do, yes.
Again, in a country town, quite often you've got a solo doctor. You may not be able to select the gender of the doctor or the cultural background of the doctor. Ethan, you're a male GP. Yeah. How do you approach sensitive topics with your patients?
Well, I always give them the option. I would always say, look, I'm the only doctor here today. Are you happy to discuss this with me? Or would you like me to try and arrange another option for you? Perhaps you'd like to talk to my nurse. And sometimes when we're taking specimens and so on, it's often helpful if the nurse can assist or collect the specimen for you. Most of the time I would say that if someone is unwell, they would say, well, you're the doctor and you're the only doctor here, so that's okay for you to examine me. But I would give the patient the option first.
Most people see you as a doctor, they've come to see you in that role. It's almost you've crossed that hurdle before you start many times. Yeah.
What about psychologically sensitive topics? What sorts of issues come up, and how do you approach things that really might be overwhelming for them?
I would say the biggest thing I see in talking about it for the patient is shame. Just shame that they are experiencing what they're feeling, not being able to make sense of it, feeling they should be coping a whole lot better than they are. Because I see a lot of trauma and deal with a lot of trauma. Sometimes the people I'm seeing are not expecting to continue to experience trauma symptoms, like they're safe, they've left their traumatic background. They're expecting to improve and feel better, and that's the very time trauma emerges. It's like the safer you get, trauma symptoms will start emerging. So they don't make a link. This is about their trauma, or if it is, they shouldn't be feeling that way. So their lack of their own resilience often shames people. and they feel they're going a bit crazy. So it's often normalising symptoms, really helpful.
Yeah.
Yeah, I think particularly when we do a lot of the training, the question that people really have is, how do I ask people about their trauma story? Yeah. And that can be really difficult for a lot of services, just to know what's the appropriate question. And I guess, what you need to know is, you're never saying to a client, tell me about your traumatic background, or tell me about the terrible things that happened to you. The questions, particularly in the first instance, just need to be a very gentle exploration of where somebody's come from. So questions like, can you tell me what brought you to Australia? Can you tell me about your family? Are often going to bring to you enough information to recognise that there has been a traumatic history. And from there, what you're really looking at is the affect or the presentation of the person. Because people can have been through the most horrific circumstances, but that doesn't mean that they're suffering from PTSD. You just want to know that perhaps there was something there in the background that may lead to PTSD, but that's only the first step in deciding whether or not they're still suffering the impact of what happened.
So I often start with a question like, I know that you might have had some bad, terrible experiences in the past. I don't need to know exactly what happened, but tell me how it's affecting you now. Are you sleeping well? Are you eating well? Are you getting on with your family? Can you concentrate in class? Questions like that. And that'll open up a whole discussion about their current symptoms, and that's really what it's focused on.
Yeah, I'll often ask, how have you arrived in Australia? How's it been? Get a starting point in coming forward. How's it been since you've arrived in Australia? And there's usually lots of issues that have emerged from that you can start linking into.
For people who are newly arrived in the country, talking about their trauma is not at the top of their list. It's about finding accommodation, getting a job, paying their bills. They're often also extremely worried about the people they've left behind, and often they'll go without meals so they can send money back home. And so those immediate issues are really at the forefront when you first meet people. And it's maybe not until months later, when they feel more secure, as Sue said, that they actually start talking about the trauma.
Yeah.
Yeah.
As a GP, and I think particularly as an isolated rural GP, I'd find a lot of this quite confronting. Obviously it sounds like you have to be all things to all people. Where do you start? I think GPs would be quite frightened about opening the floodgates once the person does start to talk.
But the first point is just, I think, making sense of what's happening for the person, and you would be amazed at how much a therapeutic intervention that can be. That I think for a lot of patients coming, they're overwhelmed either with social issues or their experience, and now the emerging symptoms sometimes of trauma that we're seeing. If you start to make sense of what their symptoms are for them with some education, if you can tell them a lot of this is very normal and responses to trauma, it's very therapeutic. Yeah, you can actually do a lot in just holding the situation with explanation and treating some symptoms as they're emerging. You can do far more than you realise.
Yeah. Do you use a lot of medication for patients? Do they need or want, or are they willing to take medication, or do they mostly just need time?
From my perspective, both.
Yeah.
I work very much with what the person, where their framework is, because if you don't work with them, it won't work. So I'll often see a lot of people I think are quite traumatised, do have symptoms of PTSD, depression or anxiety. So they're presenting with that high arousal, the sleep disturbance, the poor concentration, constantly feeling forgetful, distressed. Medication does have a role, a lot more of it is the psychological containing and the support. But bringing down arousal often helps all the other work that you want to do. I think you need to work with your client on that, what they think about it. Some will come to you saying, I need a medication for this. So there's an opening to look at what that can and can't do. Others really need, what would that do? Is that appropriate? And sometimes I'll say, let's wait and see how you go before we introduce a medication, if that's going to be helpful. Sometimes you try a medication, it really brings down the sleep, the high level of anxiety, and they really can start processing all the other issues. It makes a big difference.
What sort of medications would you
Would
be
I
using
use?
most often? Are you just using pure anxiolytics or antidepressants, or?
Probably an antidepressant's most appropriate. In practical terms, you're often working with a group that it needs to work, and it needs to be a simple medication. You've got language issues, you've got cultural issues sometimes, so a simpler antidepressant like an SSRI can be very effective. For men, a lot of men I will use something like mirtazapine at night because it doesn't cause sexual dysfunction, which can be a problem. It helps with sleep, and you just might get things moving a bit better with that. Yeah.
One thing I'd really recommend is asking the clients to bring all their previous medication in.
Yes.
Refugee clients, more than even Australian clients, can really lose track of what they've been prescribed in the past and what the purpose of that was. So if you just ask them, what are you taking, you're not really going to get a very good idea of that. So
not just what are you taking, but what were you taking?
Yeah, that's right. And can you bring it in and show it to me?
Yeah, they bring them all in.
Because people will arrive with an entire plastic bag full of medications, and particularly in the country where it's likely people have been in Australia for a little while, so have had possibly many GPs in the past. They can come in with a whole bag of medication and sort of put it out on the table and not really be able to tell you who gave that to them or what for. So ask to see it rather than just ask them to tell you.
And they often have same medication with different names.
Yes,
that they're not realising they're different tablets, and you'll be surprised the combination.
Yeah. And one of the things that does occur with my patients from time to time is that they'll have come back from, they come from China or somewhere, and they come in with an unlabeled white tablet in an envelope with a few hieroglyphics on it that turns out to be, the name of the pharmacy or the doctor. Is there a resource anywhere that allows you to identify what it is they've been swallowing? Have you come across any online anything?
I haven't found. I had someone the other day that just said to me, look, what I want is just a little round white tablet. That's the one I'm taking. And it could be, hoping I would know, Yeah, very difficult. I haven't found a resource yet.
Okay, well, we'll put that one in the too hard basket for the...
It's probably also worth mentioning that pharmacists are allowed to use the interpreter service now. So that when people are going to the pharmacy to pick up their medications, the pharmacist is actually permitted to use TIS. So it's probably worth talking to your local pharmacist and just letting them know, especially if you have lots of patients who don't speak English.
And just as a simple thing, I'm often, when I'm prescribing, say, 2 medications, one for night, one for the morning, I'm writing a note to the pharmacist saying, could you put a red dot on the nighttime medication on the box so that this person knows that's the nighttime one. Don't assume they can just read the English.
Yes, I'm thinking also that I will tend to, prescribe a generic, but I'll try and prescribe a generic and then hit brand substitution not permitted and hope that the chemist will actually give the same brand the next month so that it's not yellow one month and blue the next.
Yeah, that's what keeps changing,
Once a patient is recognised as a refugee and they settle somewhere, what happens to them, particularly if they're settling out of the metro area?
In WA, refugees are unlikely to be primarily settled, have their primary settlement outside the metro area. So most of the people coming in through the Commonwealth program who are in the queue, so to speak, actually have a settlement caseworker who helps them settle in Perth, find housing, get the kids to school, register for Medicare, and they get that support for about 6 months. There are some families who are coming in through the sponsored refugee stream or the family reunion scheme who are going directly to the country. So they're going to places like Katanning, Mount Barker, Albany, where often there's a male member of family who's already there working, who sponsored them. Families coming through that stream really have no other supports apart from that relative.
Yeah.
So they're really relying on that relative to get them registered with Medicare, get them to school and so on, and make an appointment with a GP.
Okay, and when somebody is recognised as a refugee, they can automatically register for Medicare?
It'll be on their visa that they're a permanent resident, and then that opens the door to all the other services. So once people have a permanent refugee protection visa, then they are Australian residents for all intents and purposes.
Yeah, and in the interim, what happens to them if they need to access medical services? Do they have to come through a place like this?
You've got two different situations. So the vast majority of refugees in Western Australia are coming from offshore, so camps in places like Africa or Thailand, and the moment they set foot in Australia, they're permanent residents and able to access Medicare. The complications arrive with people who arrive by boat and are still waiting for their claim to be processed, so they're not recognised as refugees. And in that case, the people living in the community are on bridging visas. They generally have access to Medicare, but it can be limited. It's a bit of a complicated situation.
A bit like the English people who can get essential medical services only, but
that's right, yeah.
Can't get their facelift this week.
Yeah, look, again, it would be very rare for an asylum seeker in that situation to be living in a rural area, but they will have access to a support service, which is called a Status Resolution Support Services, and the GP would be able to contact that service and just check exactly what it was that person was eligible for.
Sometimes a cultural background is something that we can't hook into very easily. Aisin, you were talking about women who'd undergone what we call female genital mutilation and they call normal. Could you talk us through that a little bit?
Yeah, so over the past 10 years we have seen women coming from countries where female genital mutilation is practiced, and amongst the community members usually they refer to it as circumcision or cutting. It would be a term that some people would be familiar with.
In fact, just using the term mutilation can, particularly if you were to use that with a client or a patient, would maybe be the first step in not allowing them to talk about it. So,
so
many
despite
of
the fact that they use this as a term in our medical literature, circumcision would be the term that they would use?
Certainly it's a less judgment-laden term when you're actually working with a client.
It is important to remember that it's a cultural practice that's not related to any religion. It is practiced amongst Muslim, Christian and even some Jewish communities in the Horn of Africa. It's a very ancient custom. And for communities that practice it, they really believe that they're doing it in the best interests of the child. It's seen as a positive thing to do. Now, of course, when they come to Australia, we have laws that say that it's illegal for it to be performed here, and also it's illegal to take a child overseas to have the procedure done. And I suppose the tack that we take in our clinic is that when we see someone from a country where we know it's prevalent, we'd ask the question something like, you've come from Somalia and we know that many women in Somalia have had female genital cutting done. Has this happened to you or anyone in your family? And if they answer in the positive, then we would ask, are they having any symptoms related to that? Are there any problems they'd like to talk to the doctor about? It's a really important question in the antenatal setting. Yep. So when you're planning a birth, it's important to know whether any extra procedures are going to be required before the birth of the baby or during labour.
Are there any other sets of words that you use for asking any other kinds of sensitive questions for your clients?
When talking about mental illness, I probably wouldn't use the word depression. I'd talk about stress, or A lot of the people from South Asia and West Asia talk about tension. I feel a lot of tension.
Yeah.
And that seems to relate to their physical sense as well. Nervousness, restlessness, they're words that people seem to understand, but probably sadness or, rather than depression.
Particularly when you're using quite technical psychological terms. Again, when using an interpreter, it's often a good idea to, if you want to, perhaps use that word such as depression, but then make clear that you're going to explain what that means. So, I will often say, I want to ask you some questions about depression. Let me explain what depression is. And part of the reason for doing that is otherwise the interpreter may use their words to explain what depression means. So you want to be able to put it in a way that you think is going to be most understandable for the client rather than relying on the interpreter to do that.
Mm-hmm.
Yeah, I fully agree. Stress is much more understandable. Yeah. And normalises as well.
Yeah. When we've got a patient in front of us, often they're not, their torture or their past traumas aren't actually what's on the table. They want to talk about their ingrowing toenail for 5 minutes, but you get a feeling that there might be some other agenda there. What are the sort of the red flags that say to you, this patient really needs to talk about something else?
Look, they very rarely say, I need to talk about trauma. You start to pick it in the interview, and it's very much the physical symptoms that people are presenting with. So it's the chest pain, the shortness of breath, the sleep disturbance, those sorts of things. You're beginning to think, could this be trauma? Is this the arousal of unresolved trauma that we're seeing, and how is that presenting? For example, I did have a man from Iraq that presented with intractable sleep disturbance, and that's not an uncommon presentation that you're trying to deal with. And I knew he was very traumatised. He knew he was traumatised, but he couldn't sleep. He was up all night, and he would sleep at about 5 a.m. So often at night he was walking in the parks, walking around the house. We tried everything. More and more medication, more and more looking at his trauma, and eventually just sitting down and talking to him about sleep and his past experiences I realised I was re-traumatising him. His sleep when he was imprisoned in Iraq, he was in a large area contained at night where people were sleeping on the floor, and one of the things, the guards would come in and they would often shoot people randomly at night in their sleep. So his strongest survival mechanism was to stay awake, and to stay awake through the night. And that trauma was still playing out. He needed to stay awake at the moment, and getting him to sleep was very traumatising. It was like shutting down to his survival mechanism.
Yeah.
So once we could work that out, it was working with him how to manage the night in a different way, how to just move his sleep to the early morning, and getting out of this attempt to override what was his safety mechanism at the moment. So that was really helpful to understand trauma as a background to what we might be managing.
Ethan, have you got any stories of patients that you could share with us?
I think probably a slightly different approach, and that is that we need to recognise that concepts of wellness and healing are very, very culturally based. So we have in the West a very sort of biomechanical explanation for health, but people from other cultures may have a different explanation for their well-being and health, and often they're more holistic and incorporate spiritual aspects as well, or maybe other concepts. So slightly different to Sue's example is I was explaining to someone that they had thalassemia, and this is a woman who grew up in a village in Burma. She's never been to school, and she asked me, could this be the result of sorcery?
Yeah.
So she had a very different concept of health and to explain what was happening to her than I have, and there's this huge cultural gap, because it's very difficult for me to explain to her about genes and chromosomes and, is it heterozygous or homozygous and so on. What's often useful is to ask the patient, what do you think is happening to you? What is your explanation for the symptoms you're experiencing? And that's often very enlightening. And then the follow-up question is, well, in your culture, how would we approach this? How would we try and treat this? And often recognising that people from non-Western cultures often come from collectivist societies, so the community is often involved as well. So they may want to involve their family in the treatment or their religious leader or something like that.
It is the best question to ask. I always ask it to ask them, what do you think might be causing the problem?
Yeah.
You know? And sometimes people say it's the stress and the trauma,
Yeah.
And it can be your door if you want to open it. Just following up on what you're saying about the interplay, a man I saw last week who was in his 60s from Iran was presenting really with a lot of trauma symptoms and depression, but he was worried about his hypertension and his blood pressure and his constant gastric distress. He was on a lot of medication for gastric ulcer, gastritis, reflux, and that was really worrying him. In his history, he wanted to talk about his stress, and his stress was the death of his son 7 years ago in a kidnapping, and it was very evident that's what was distressing him. When you hear trauma sometimes, what I'm looking for is how prepared was that person for it at the time? What impact did it have? Because it will really help you understand what happened to the body. So when I just asked him a few details, I said, were you present when your son was killed? He was able to say, I got up and I was eating breakfast when someone ran in and said, your son's been taken in the street. And I threw my food up in the air and I ran outside. As we talked about that, I was later able to say to him, when he was constantly talking about his stomach problems and how difficult they were, I said to him, in your story, I remembered you were eating, and it seemed a really important detail. You had told me you were eating at the time you heard this news. Do you think things have ever settled down since then? And he said, my stomach has never settled from that moment. I've never really been able to eat since that time. He said, I feel everything in my stomach. So that was helpful to understand what we're dealing with now as well, that there's a trauma in the physical presentation.
Now, it sounds like it's quite a stressful job to listen to this. I'm assuming that there are some fantastic success stories and that there must be some great joy in allowing people to kind of settle into a community and help them adapt. But what happens with the great weight that you carry around of all the dreadful things that have happened to people?
Self-care is a really important aspect of working with trauma. Assets does also run a compassion fatigue training, which is going through the different important elements of how to be able to look after yourself when you're doing this work. When I do that training, when I've been a participant and when I've run it with other people, actually the area that I always find the most uplifting is when we get to talk about the reason that we do this work. Because the commitment to the clients is actually most often what can get you through, when you have a sense that it's really meaningful work, and your contribution to someone's recovery is really valuable to them. So, keeping that in mind, why do you do this? Why is it important? Is part of what can get you through.
Yeah, Sue?
Yeah, look, I agree. It's always helpful to have somebody, a colleague, to debrief sometimes from just something you've heard or experienced. Always helps unload that a bit. But look, I think most of the stress comes in any of our work when we don't feel we know what we're doing. It's like when you have more mastery over what you're doing, the stress comes down, and this work can generate a lot of feeling of helplessness or there's nothing I can do. When you're doing something, it's being able to trust it does make a difference, that you have some skill to keep offering in this situation. Yeah.
Asa?
Yeah, I think it's really important to recognise that vicarious trauma exists, and it's important to have some safeguards for that. Within our unit, we arrange with Assets to provide some training once a year around vicarious trauma for our staff. The staff can always access employee assistance programs, and I think the Royal College of GPs has something similar for GPs. They can access 6 sessions of counselling if they require. I think the other thing to say is that really Assets sees probably the most difficult and intractable cases. Most GPs may see one person, in their career who has severe PTSD of this level. Certainly in my clinic, probably out of 1,200 people, 1 or 2 patients a year will present with severe PTSD symptoms. So not all refugees have PTSD.
Exactly.
The refugee experience is quite diverse, and that's why it's important to get that background information at the beginning.
I think it's just watching somebody on that journey, and I can think of a number of clients that I've seen where there was that sense of hopelessness at the beginning. They were so isolated, so closed, just felt so unwell, and over the period of a year or 2 years, you then see them coming into the office and they're very vocal, they're very social, they're doing all sorts of things, and it's a real transformation, and that's great.
It might seem facile, but I think offering patients hope is the most important thing we do, and it's beyond our prescribing, and it's that therapeutic relationship. Offering hope is probably the most healing aspect of what we do.
And offering a good relationship sometimes, when everything's been so traumatic, to offer something.
All of a sudden there's a cheer squad there for
There's
you.
a decent relationship, yeah.
That's great. Thank you very much for joining us today and sharing some of your journey with us.
Thanks to Marnie Williams, Dr. Sue Lutton and Dr. Ethan Thambiran for their time. And if you'd like to contact Assets regarding a patient of yours, or you're interested in the workshops they run, all their contact details are on the Rural Health West website. Now, Isha is a multicultural women's health centre based in Mirrabooka. Dr. Olga Ward met with the centre's GP, Dr. Christine Reid, and Information Officer Rukmini Ayal. They chatted about some of the challenges that migrants can face when trying to access healthcare in an unfamiliar system.
So Rukmini and Christine, welcome to the program.
Thank you. Thank you.
Can you tell me a little bit about Isha and what it represents for women in Western Australia?
Isha is a multicultural women's health centre. It is funded by mainly Department of Health, and we have got here a female doctor who does the women's health checkup, and also we have got counsellor. She does counselling every week.
Yep.
We have got carer support program. Also we have lots of other programs, family support program, and we have got activities like sewing classes every Friday where the women come and meet, and it's mainly the idea is to socialize. And also we have got yoga classes, exercise classes, things like that.
What's your role here?
I'm the information officer. I work in reception, providing information to clients and also getting information from the other agencies. And I usually refer client, if we don't provide the services, we refer clients to other service providers.
You find something that will meet their needs.
Yeah.
And Christine, what's your role here?
I just work in the medical clinic and I'm here 2 or 3 days a week, and we advise ladies that we really just do women's health. So I'm a GP, but in this place we encourage ladies to have their own GP, but that where their needs are not met with the GP, they can come to us for women's health.
Yep. So what sort of problems, medical problems, do you see that come through here that cause difficulties with their regular GP, if you know what
So
I mean?
many ladies just will say, I prefer to see a female doctor and my doctor is a man, and it's as simple as that. Sometimes they come for routine women's health checks, and sometimes they come with an embarrassing problem that they really just are too scared to talk to a male doctor about. It's mostly gender related, mostly, I'm good just because I'm a woman, which is a lucky place to be for me.
And then how do you communicate back with their GP to tell the GP that the pap smear has been done, or that the patient's chlamydia has been treated, or that you have maybe a concern about domestic violence or something?
So on most of the tests that I order, I ask the lady, who is your GP? Do you agree? Can we send a copy of the report through? So a lot of the communication is just the GP sees the pap smear, oh good, it's done, put it in the file. Sometimes we communicate via letters, and sometimes the lady will leave with a letter saying, I've seen your patient, I've done this examination, and they will take it back, and the GP stays in charge of their care.
You're Australian, Christine.
Yes.
Do you have any communication difficulties or strategies, or do you need to use an interpreter? Or
There's lots of things, I think, that make it hard for ladies to talk about embarrassing problems, and some of those an Australian would have with me as an Australian doctor. But this place is quite challenging in that way, that there are difficulties even with making the booking. Then there are difficulties with understanding the need to book an interpreter. We use probably interpreters for maybe 30% of our visits, and it's just decided by the lady herself. Would you like an interpreter? She says, yes, we book one. And that creates a number of challenges. For some ladies, actually, they're quite concerned about confidentiality, not so much that I'll tell someone, but more that the interpreter might give information back to their community. Sometimes we have to be aware that that's getting in the way of them telling us the full story.
Would you then use a telephone interpreter service
we
or something?
We sometimes use telephone interpreting services. We sometimes ask the telephone interpreter, where are you? If you're in Queensland, they're happy. If you're in Western Australia, they're not happy. Some ladies will ask us to get an interpreter in their second language, because their first language is their own community. Their second language is more anonymous.
And Rukmini, what was it like coming to Australia? You came as a student.
Everything was new, like system where everything the new, and my English wasn't that good enough. It was good, but the speaking wasn't good enough, and the accent, I would find difficult to understand, the Australian accent, or the people who are coming here from all over the world. So one person has a different accent, and the other person has a different accent. So it was challenging.
Where did you come from?
From Nepal.
And what was it like landing in Australia and trying to negotiate the health system?
It was very challenging in the beginning. Before I applied for the visa, I had to put the health insurance, so which was private health insurance, Medibank. So when I came here, I already had that insurance with me, and the other thing was very challenging, to find where to go for the GP, where would be the hospital, because everything was new. I didn't know anything, and I had very limited computer knowledge as well back then, 6-7 years ago, and I would have find difficulties to search the services. Medical services over here. So even if I'm sick, I wouldn't be going to see the GP in the beginning, a couple of months or 6-7 months. So yeah, it was very challenging. Yeah.
So where do you look when you first come to somewhere completely unknown? Where do you look, and whom do you ask?
I had one friend. Luckily, before we come, they were here already. So we had asked with them, because they were also new, 6 months before than us, but at least they knew the basic things. So they helped me. Yeah.
And when you first went to the doctor, what happened? How did you find it? Yeah.
It is a bit funny, because back home we usually go to, even if it is for simple things, the flu or anything, we usually go to hospital, the government hospital, and where there would be the separate part, separate section where all the GPs would be working, and then there will be one section like where the emergency cases happen. So when I came Australia, I didn't know I had to go to GP before I go to hospital. So I straight away went to hospital, and they were laughing at me, like, what do you think the emergency about? Like, you had flu, so why do you think this is an emergency case? And I didn't know that, because I was thinking hospital, they will provide me the services, and I told them, I explained to them, and that was okay. They gave me the certain, like, the paracetamol or something. So yeah, it was a bit tricky.
Christine, how do you find you settle your patients down, or how do you make them kind of feel welcome into the health system?
Yeah, I guess by the time they've come into my office, they've already done a lot of negotiating. They've already found the place. Even this centre is very difficult to find. There's no signs. We're in a City of Stirling building underneath the library. Very difficult to find. So by the time they've found me, they've already negotiated quite a bit. Isha is a wonderfully warm place. It's a place where people walk in and already they feel welcome, and that really helps me a lot. There are smiles and friendly people at the front, saying, welcome, have a seat, make a cup of tea. I think all of that makes a difference. But I think sometimes I just try to ask open-ended questions. I try to give people time to explain, what they're worried about, and I think that makes a big difference instead of jumping in with a kind of medical agendas. Sometimes then we find out the real thing that's worrying someone.
Yeah. Rukmini, what happened to you when you were trying to explain things in your extremely good but correct English? How did you manage to negotiate Australian slang?
Yeah, most of the time I had to use my hand, like the facial expression, or if I had pain in my tummy, or if I have lower tummy, I had to show them and say lower tummy, like things like the using the hand and like eyes, the facial expression. Because in the beginning I was still, scared to ask them what that meant, please, sorry, like those kind of thing. I would be scared to ask, can you please repeat, those kind of questions. But I'm now comfortable to ask, to repeat. I would be saying, I didn't understand, can you please repeat this word again, things like that. I have learned, yeah.
Christine, do you have a similar problem communicating with your patients if you ask them if their bowels have moved and the glazed expression comes over their face?
I tend to find that I use as simple language as I can, and I also find that sometimes I'm using 2 or 3 words for one thing, so they may recognise one but not the other two, and I think that sometimes works. You can see that recognition in the face of the word that they do understand. I understand the question now, then they answer. And sometimes just re-clarifying, saying back to them what I've heard, and just making sure that we're understanding each other.
Rukmini just said that sometimes somebody would tell a joke and she would laugh even though she hadn't understood the joke. What are the clues that the person maybe isn't quite getting what you're saying, or what you're not quite getting what they're saying?
Certainly there are some ladies who come and they want to please, they don't want to upset anyone, so they'll say yes to every question. They will not answer, do you have any questions? No, I don't have any questions, and they leave, because they've still got a question. So it really is just, I guess, about being quite friendly, being quite open, sometimes laughing at myself, creating an atmosphere where there's a bit more room for them to ask questions. But I ask and take a few angles on a question just to make sure that they have understood that we're on the same page.
And Rukmini, finally, what was it like trying to access Medicare?
Yeah, so I had come to, this is 7 years I'm in Australia, so for 2 years I had to study, and then since that time I used Medibank private health insurance cover thing. Then I got my temporary visa. Then I could apply for Medicare.
So up till that time Medibank private actually covered your general practice?
Yeah, that did.
Did you know that it did?
In the beginning I didn't. For first year, I was thinking maybe even if I have got Medicare medical insurance, if I go to see GP or anything, it will cost me like 100%. That never covered like 100%. Like it was, I think 40% they would have covered. But even like in the beginning, I was thinking it's 100% I had to pay. Then the second year, then I knew, because I was familiar, I was searching, you know, I had more information, and I knew that Medibank will cover this percentage. So I would be going. I had, you know, gone to see GP by then. So, but Medicare is different. Like it covers everything. Like if I go to, because I became pregnant after I got, like, you know, my permanent residency. So it's very surprising for me, because if I was pregnant back home, it would cost me lots of money. But here it didn't cost me anything. Like, you know, since from the beginning to the end, like the delivery time, didn't cost me anything. So it was very,
So
yeah,
that was at
quite
least
happy.
a pleasant
Yeah,
surprise.
happy with the Medicare. Yeah.
Going back to that initial time, if you'd had an emergency, what would have happened? How would you have sought help?
I didn't know that I had to call 00000 by then. So I don't know. I would be maybe just going to the neighbor, knocking the door and telling them, you know, I'm this situation. I would maybe ask people for the help, but I wouldn't be knowing myself. Yeah.
And Christine, any final words of wisdom for looking after our patients?
Yeah, I think some of the challenges that I face are after they've already arrived, and in some ways we can work that out. But sometimes I think when we realise that people are not familiar with our system, we realise we need to explain quite a lot more. So, for example, if I write a prescription for the pill, for example, I show the lady, this is what the packet looks like, here's where you start. I explain everything about how to take it, and then I give her the script. If I don't explain to her what to do with that piece of paper, she will come back in 3 months for the follow-up visit and show it to me. We need to explain to people, this paper you take to the pharmacy, they will sell you the medicine. Little things like this make so much difference. We assume people know what a script is. We assume people know where to buy condoms. We can show them how to use, all good, but if they don't know where to buy them, they won't work. So we have to actually think really sideways. I want to order a test. Now I need to help her to actually do this test, because handing her the paper is not enough. And that's what's challenging. And it makes a difference to the medicine.
Christine, sometimes I have Indigenous patients or patients from a different culture, and it's quite difficult to ask them about certain taboo topics or you know, things that they might find quite uncomfortable. I'm guessing less of a problem with women talking to a female doctor, but do you ever come across a taboo topic that's difficult to talk about?
I think there can be a minefield of, you know, things that one should ask. Being female does make it easier, and I think being Australian in some ways makes it easier, because a lot of people who've travelled here are very gracious and very kind to Australians who are not a little bit clumsy sometimes when it comes to culture. But every now and again a lady will say to me, "Oh, you shouldn't ask, you know, someone from my country that question." For example, I asked her, "How many children do you have?" Simple question, but in my culture, if we count our children, we believe something bad will happen to one of them. So after that, I ask a more open question. I say, "Do you have children? Do you have sons or daughters?" I wait for them to tell me, if they wish, how many they have. They tell me, "You ask me how many, I will only tell you about my daughters, or I won't count them all. I'll give you the wrong number because it's bad luck." So interesting things that we don't find out unless you really listen, unless you let people tell their story. Yeah, and so maybe I'm asking taboo questions all the time. I'd always try and listen to find out if there's something that's important to that lady that I should ask in a different way. One lady I said to her, "Now we will do the pap test." I've explained it all. I said, "Now take off your underwear." She looks at me really shy. She says, "I don't wear underwear." Very culturally, they won't. So then I changed my instruction for next time. If you have any underwear, take it off. So all the time I'm learning, all the time I'm listening to people, hearing where they're coming from, and that makes a difference for the next person, Trying to keep an open mind, trying not to let my culture, my preconceived ideas making it, imposing on them.
Well, that's all we have time for in this webcast. Thank you to Dr. Reid and to Rukmini for sharing their stories. And we'll return in June with a program on genetics. I'll see you then.